to Melissa.
It's nice to meet you all. My name is Dr. Sarah Tassin. I am pediatric hematologist and a transfusion medicine physician, and I collaborated with Melissa Green, who is our nursing extraordinaire from the Nursing IVIG program, to put together this presentation on intravenous immunoglobulins in pediatric patients. And we are going to really talk about just a very brief overview and then the details of ordering an infusion piece. So I want to acknowledge that we are gathering on Treaty 2, 4, 6, 8, and 10 territory and the homeland of the Dakota, Lakota, and Métis. Recognizing this history is important to our future and our efforts to close the gap in health outcomes between the Indigenous and non-Indigenous people by knowing what the land and the traditional people of the land offer us. I'm going to be talking about the overview of what the product is, how it's made, and all of those things just for understanding. Then I'll go through indications. Melissa will talk about IVIG dose and administrations. If we have time, we would love to talk about the adverse events. If we don't have time, that will still be available to you in the form of the slide decks for you to access and review. Some of these things are very more physician pertinent, and some of these things are more nursing pertinent, and they're kind of mixed in between. So if we are getting too physician heavy and there are no physicians on this meeting, just let me know. So how is IVIG prepared? IVIG is basically prepared, what is it? It's basically a pool of IgG immunoglobulins. It's produced from plasma, commercially procured from about 10,000 to 60,000 donors at a time. So after that plasma is collected, it goes through purification and extraction of IgG from the donor pool plasma happens. And once that IgG is extracted, it goes through extensive procedures for viral and microbial inactivation. Then it's stabilized, it's freeze-dried, and it comes to you in the form of a bottle, actually. Yes. And there are additional steps which are taken to reduce the anti-A, anti-B antigens in this, and we will talk about that in more detail a little down the line. So how does it work? To be honest, it depends upon what you're talking about, and nobody really knows completely. So the first thing is IVIG manages autoimmune diseases. So diseases in which your own immune system is causing destruction of blood cells or other cells in the body. And it does so by binding to macrophages and stopping them from engulfing the affected cell. It acts by increasing the regulatory T cells, which causes the immune system to take basically a chill pill. It reduces inflammation, and then it inhibits complement, which is responsible for a lot of breakdown happening within the blood vessels. And all of these different mechanisms play a role in different scenarios, but it basically has a lot of variable suppressive effects on the immunity. And then it's also used for immune reconstitution or provision of immunity, a passive immunity in patients who have immunodeficiency. And it does that because when you collect this large amount of immunoglobulin from a bunch of donors, it contains IgG antibodies. And these IgG antibodies are directed against any bacteria, viruses, antigens, pathogens that particular person has come across in their life. And because of that, they can actually, it just becomes a source of antibodies that the patient themselves did not produce to be available to for them to fight infections. Of note, the dose for immune reconstitution and the dose for autoimmunity tend to be different. Autoimmunity is much higher doses, 1 to 2 grams per kilo. Immune reconstitution tends to be like 0.5, 0.6 per kilo. So why do we give IVIG? Well, we try to stop autoimmunity, but there are hundreds and thousands of autoimmune conditions. IVIG has been trialed for every autoimmune condition. It is not effective in every autoimmune condition. So it's very important when the IVIG order comes to review the evidence-based criteria and make sure that it's being given for the right reasons and not for the purposes of just trialing or being used in indications where it has proven that it's not effective. And then obviously the indication is immunodeficiency. And when we talk about immunodeficiency, what we are trying to say is patients who do not have the ability to make antibodies against bacteria and viruses. So these are patients whose B lymphocytes are either low or they do not work right. And this could be congenital and this can be acquired. Hence, their immunoglobulin levels can be low. And the other thing is that these people also usually have a history of getting frequent infections, which are bacterial in nature and quite commonly are upper respiratory. So like your sinusitis, pneumonias, air infections, all of those things. Normal serum level of immunoglobulin tends to be about 6 to 7 milligrams per DL. IVIG supplementation is done in patients to maintain a trough level of 6 to 7. So when I say a trough level, it means that when we give somebody IVIG infusion and they're due for it again in 4 weeks, what we expect is that the level will be still hanging around 6 to 7 at the 4-week mark. You know, if the patients are still having significant infections, then there are situations where the levels of immunoglobulin in the body that we are targeting are higher, sometimes as high as 9. And this can be accomplished by a higher dose, and this can be accomplished by more frequent dosing. IVIG has a half-life of about 3 weeks, okay? And it then slowly decomposes and goes away over the next 40 to 50 days. So it stays in your plasma for quite a bit of time. And that's kind of the reason that it's given every 4-ish weeks in many of our autoimmune conditions. There are other immunoglobulin types, though I doubt that you guys will be going through them in a lot of detail. One of the other immunoglobulin type is subcutaneous immune globulin. Subcutaneous immune globulin is quite commonly used for the purposes of management of immunodeficiency. And the people who do it tend to do it at home, and it's usually a home administration program. It's given weekly, and its complication rate is quite markedly lower than what we see from IVIG, okay? If somebody is on IVIG for the purposes of immune reconstitution or management of immunodeficiency, and you have to convert it to subcutaneous immune globulin, it's just very important to know that subcutaneous immune globulin is given weekly, but the total dose over 4 weeks is similar to that of IVIG. So for a 20 kg kid, if they are getting 20 grams, let's say 10 grams of IVIG every 4 weeks, they will be getting like 2.5 grams of subcutaneous immunoglobulin every week, kind of a thing. And then we have solvent detergent IVIG. Solvent detergent IVIG is used in very rare conditions where patients have anaphylaxis and they have undetectable levels of IgA antibody. Why that happens, we will come to that in a minute. Intramuscular immunoglobulin is only used by public health for certain indications, and it's actually the first type of immunoglobulin to be produced, but is not utilized anymore. And at this point, I have 2 more things to go through. I will go through them quickly. Is that okay? Okay. So before you infuse or think about infusion, you have to think of certain things. Is the indication correct? Are there effective alternative medications? If the patient has got an IVIG in the past, have they had any reactions, and how are the reactions managed? And then is the dose adequate? So if you're overdosing a patient, you are putting them at risk of lots of complications. And if you're underdosing them, then obviously you're affecting the efficacy. Then the other things to consider is the consent of the patient, right? So if the patient consent for blood is valid for 12 months, some facilities do require separate inpatient and outpatient consent forms. I hope that practice eventually goes away, but that's crazy. You need a completed pre-printed order set by the most responsible physician. For autoimmune complications, it's valid for 6 months. And after 6 months, we expect that the physician will review the patient and then renew the order if needed, right? If clinically indicated. For immunodeficiency patients, we are going in a situation where we are accepting orders up to 12 months on the pre-printed order set, but not in every single case. It depends upon how clear-cut the situation is and how much reassessment it needs. And then updated height and weight. And as we all know, in pediatric world, kids grow really fast and their weight and height changes quite significantly. If there is more than a 5% change in height in weight, then those changes may be needed. And then hydration status. If you are dehydrated, the risk of acute kidney injury in patients at risk of renal failure, the risk of any other IVIG-related adverse events is much higher. So it's important for them to drink plenty of water before they come for their infusion, and for you guys to keep a close eye on the hydration status if they're inpatient. The other investigations that you do, you look for ABO. So other things that you have to do just before you give somebody intravenous immunoglobulin for the first time. So you need to get a blood group and an RH type because of considerations pertaining to hemolytic anemia. Okay. You need to do CBC, retake, and hemolytic markers, because if you are an O person and if you are an A or B patient and you're receiving IVIG, it comes from O donors. So then it has passive anti-A and anti-B in the plasma in it, and it can cause hemolysis. Usually happens 7 to 10 days post-infusion, and it can be quite severe in children. So it's important to watch for that. You need at least a baseline level of immunoglobulins, and you need renal function just to make sure that they are not patients at risk of worsening of renal function and they're not dehydrated. And then for ITP, you have to look at how well the platelets are responding to consider if it is a useful option in subsequent times. And that's where I stop and I tell Melissa to come on. So I'm going to mute myself and I'm going to ask Melissa to come and start talking. And I'm going to say that, and I'm going to advance the slides as needed. Okay.
Hi, my name is Melissa Green. I'm the registered nurse, IG nurse navigator for Northern Saskatchewan. We're going to talk today about ordering IVIG. If you would like to advance the slide, that would be perfect.
Okay. Sorry, what is that doing? Oh, don't do that. Don't do that. See that? Okay, perfect.
All right, so we have a video on the pediatric order set already on sasblood.ca. So you can view that in your own time if you want. I'm only going to talk about the information that is pertinent for administration of IVIG. So this is page 1 of our order set. It is a hefty order set. It is 5 pages. 4 pages do need to be signed by the physician. So on page 1, your patient clinical information is your pertinent information, which we've highlighted here in red. It includes your diagnosis, indication for IVIG therapy, and it will tell you if they have had a previous reaction to IVIG. Okay, can we click again? And that's what it looks like bolded. We can go forward again. Page 2 of the order set looks like this. And on this page, we are going to be talking about the IVIG dose and frequency. So we've highlighted it here in red. So on that, you will see you have a weight and a height, and it will talk about if you're using an adjusted body weight, which will also be completed in that box. You'll also note that it says dose changes are required when a height or weight change is greater than 5 kg or 10% from baseline. So when are we going to use adjusted body weight for pediatric patients? The IG Stewardship Program created a magnet, which is here. We did send it to all the transfusion medicine labs. We do have extra left. If you would like to request one for your infusion clinic, you definitely can. Just reach out to the Stewardship Program. Basically, we're assessing the patient age. For patients under the age of 10, we're not expecting them to be greater than 20 kilograms, so we're going to use the actual body weight. Patients age 10 and older, to use the calculator, they have to have a height of 152.4 centimeters and a weight greater than 20 kg. So if they don't meet either one of those criteria, the height or the weight, you're going to just use their actual body weight. If they do meet the height and weight criteria, you will punch them into the adjusted body weight calculator, which is on the next slide, which it looks like this. So the adjusted body weight calculator is used. It's supported by the National Advisory Committee on Blood Management to help to adjust, basically dose the patient properly. So it comes in, it's automatically preset to male. You're going to enter in the gender. So if they're a female patient, make sure you toggle that over to female. You're going to enter in the height. If the height isn't 152.4 centimeters, you're going to get that little pop-up from Alberta Health Services. And then you're going to enter in the weight, and you'll get the patient is under ideal body weight, therefore use actual body weight. So it's kind of foolproof. If you punch it in and you get either one of those screens, use actual body weight. I would like to say that the IVIG dose calculator does round. That is on the next slide. It rounds to the nearest 5 grams. So for this patient, their dose would be 22.6 grams. However, the calculator automatically rounds it to 25. With pediatrics, less than 20 kilograms, we are not rounding IVIG at all. If the patient is over 20 kilograms, we are rounding to the nearest 2.5 grams. So less than 20, no rounding. Over 20, round to 2.5. Next slide, please. Page 3 of our order set. We're getting there. So page 3, you're going to see your IVIG dose. You're going to have your maintenance dose, which will include a frequency schedule. So it can be repeated anywhere from 2 to 12 weeks. I've seen IVIG given. And we approve it based on a number of cycles. If it's every 4 weeks, it's 6 cycles in 6 months. And the order set currently expires from the date, 6 months from the date of the first transfusion. So it does also talk about the infusion rate. So if a patient has a previous reaction, one of the first steps that we try to take is to decrease the infusion rate. And you will see the reduced infusion rate is checked off, and it'll give you a maximum infusion rate. Next slide. Also on this page of the order set is pre-medications. Pre-medications are only to be given if the patient has a previous documented history of reaction to IVIG. I did want to highlight too that IVIG is only compatible with D5W. It is not compatible with other IV fluids. And next slide. Finally, we made it to page 4. So page 4 on the order set is going to have your PRN medications, essentially. So if you have a patient that has an adverse reaction during infusion, these are your PRN medications. Usually they are pre-ordered for you, so you should not have to worry. If you have a reaction, you can come here and medicate the patient as needed. I would like to highlight, next slide, the IG stewardship program and TML screening and approval box on the bottom. So on this box, you'll see dose has been verified, which means that either the IG stewardship program or lab has screened and approved the order set against the criteria document that we screen all orders against. If the dose has been adjusted at all, you will come here to see the dose. So if a dose came in at 11 grams and we ended up rounding it down to 10 grams, you would see the required dose adjusted to filled in on this box. You'll also see if the dose has been approved, and it will be signed and dated from us. And that's the end of the order set that is required to be filled out by the physician. Next slide. So we are going to program a pump for IVIG infusion using a hypothetical patient weight of 22.7 kg. Next slide. There's a few generic rules that we need to be aware of. Maximum infusion rates at specific intervals should not be exceeded. Maximum infusion rate is 4 mils per kilogram per hour for a patient. High infusion rates should not be used for patients at risk of renal impairment or for those with a history of hypertension, cardiovascular disease, previous thrombolytic event, or dehydration, as they increase your risk of thrombus formation. I do want to highlight that the Plum 360 Smart Pump for IVIG administration on infants with a body weight of less than 2 kg or for infusion rates of less than 2 to 3 mils per hour, we are going to be using the next slide. You're going to be using the MedFusion 4000 syringe pump. So anything that is an infusion rate of less than 2 to 3, this is your machine. We're not going to be talking about this machine today, so we will just go on to the next slide. I just wanted you to be aware 3 mils per hour or less needs to be on that. So a few more things to remember. So we're going to use the dosing weight from page 2 of the POS. For our pretend order, it is 22.7. And you're going to notify your ordering practitioner and the IG stewardship program of any height or weight changes greater than or equal to 5 kg or 10% from baseline. I also wanted to highlight that once a vial has been spiked, it must be transfused within 4 hours. The vial specifically, not the entire dose. So let's say you get 2 5-gram vials, you can run that past the 4 hours. The first 5-gram vial has to be done within the 4 hours. And that's just a reminder of where you're going to find the weight that you're using to program the pump, which will be on the order set. You're either going to be using the weight or the adjusted body weight to pump and put in the pump. And for this presentation, we're using 22.7. I'm ready for the next slide. So this is page 5 of the order set. It has the infusion rate table. So we've identified that the patient is 22.7. So we are going to be noticing that the initial rate is going to be 10, and then after 30 minutes, we're going to bump up to 20, and then we'll go to 40, and then our final rate should end up at 80. Next slide. So our administration steps, we're going to start by priming an unfiltered IV tubing set using D5W 250 ml bag because IVIG is only compatible with D5W. You can run IVIG on either the primary line or the secondary line. We are recommending right now that you use whatever is in your current nursing protocol. Next slide. For the purpose of this presentation, we are going to program the pump on line A. So for pediatric patients, you're going to come in here and you're going to choose your CCA first, and you're going to see that there are 3 CCAs for pediatric patients. The first is peds to 10 kg, and then you've got peds 10 to 50 kg, and then you have pediatric patients over 50 kg. If you want to click forward. And for our patient weight, we did 22.7 kilograms. So we are going to select the peds 10 to 50 kg CCA. Next slide. So to make things complicated, there's 2 blood IVIG lines in the Plum 360. We are recommending you follow your local policy and procedure until we have a provincial-wide policy and procedure, which hopefully will not be too much longer. Eventually, once our provincial policy and procedure goes live, there will only be 1 blood IVIG generic line in the pump. The transfusion medicine lab component and product catalog indicates programming the pump with the blood IVIG generic line. So we've come here, we selected our CCA of peds 10 to 50. Now we're going to search for blood. And on page 1, you're going to see the generic line. When you page down to the next page, that's when you'll find your IVIG 10% brand name lines. Next slide. Why is there 2 lines? So the blood IVIG 10% generic line, when you click on it, if you want to do just forward a couple, you're going to see forward again. You're going to see dose 1 high alert and dose 2 high alert. So can you click one more time? Why do we have 2 dose lines? So, and how do we know which one it is? So if you have an initial order set on the POS on page 1, if you note that they've checked off that it's an initial order set, you're going to select dose 1. The product monograph defines dose 1 as any first-time IVIG infusion. Dose 2 can be any subsequent IVIG infusion. And the reason for the difference is there is a higher upper infusion rate allowance on dose 2. Next slide. And the blood IVIG 10% line, when you select that line in the pump, this is what it's going to look like. You're going to get GammaGuard, Gamunex, Octagam, and Privigen. So for the purpose of this presentation, I've just selected the Privigen line. And when you get that selected, you're going to see this clinical advisory stating that the Plum 360 is only used if the flow rate is greater than 3 mils per hour. This clinical advisory is identical in the blood generic 10% line once you've selected your dose. The main reason for the differences between the brand name lines and even the generic lines is the dose lower soft limit, the dose upper soft limit, and the dose upper hard limit. They all vary per product and per line. And that is essentially why there's the different lines.
And
If
I
you
would
want to
like to
toggle
just say
for
that there is no real difference, between, like, the products are not different enough to have that differences. It's just the way the pumps.
Yeah, it's just the way the pump was ended up being programmed. And so then you will still see this clinical advisory on the generic line also. It's the same. And so Plum 360 multi-step infusion. So we've selected our CCA, which is weight-based, which was the 22.7. We've chosen our medication. We're going with the generic 10% line, and we're going to give this patient a 10-gram vial, which should be 100 mils. And we're going to start the infusion following the rate table. Next slide. So this is where doing the multi-step programming gets a little bit complicated. The total volume of a 10-gram vial is 100 mils, which is 0.1 gram per mil. For the weight of 22.7 grams, the total volume infused between step 1 and 3 is going to be 35. So therefore, when you enter in step 4, your volume to be infused is going to be 65 mils. And I have slides on the next one to show you what this looks like, just because it's a little complicated. So our initial rate is 0.5 mils per hour or 10 mils per hour. So to program a multi-step pump, you're going to come to the pump. You're going to select your generic line, dose 1 for this patient, and we're going to hit the multi-step button. And then you're going to program in your patient weight. The screen will then look like this, and you will put your rate in of 10, and the volume to be infused mathematically will be 5 because you're going to run it over 30 minutes. And then you're going to program in your 20, your volume to be infused will be 10, and your 40, your volume to be infused will be 20 because it is 30. You're going to add a callback so that the pump will notify you when it's changing the dose, so you can get notified to come do your vital signs. And then you're going to toggle down to steps 4 to 10, and you're going to enter in your final rate of 80 with your last little bit of volume to be infused is 65. and that will bring you the total volume of 100 mils infused. And you're going to add your callback and then press start to confirm. Next slide. So last thoughts on the pump programming. You want to program the pump on the rate, not the dose. If you can see here, the first pump is programmed with a rate of 80 mils per hour, which actually gives you a dose of 3.5. As per the table, the maximum rate for that weight range was 80 mils per hour. If you go in there and pump and program that pump at 4 mils per kilogram per hour, because this kid is right smack in the middle of that rate table, you're going to get a rate of 90.8 mils per hour, which is above the recommended infusion rate. So always, always, always use the rate, not the dose, to program the pump. Next slide. So for priming the pump, one more time to reiterate it all, you've got your unfiltered tubing, you've primed it with D5W, you've got your medication line chosen, either brand or generic, you've got your CCA based on weight. We're slowly increasing the infusion rate using the rate, not the dose, to program the pump, and noticing that a vial can only be spiked within 4 hours. It is always okay to do a slower than max infusion rate for patients with adverse events. Next slide.
Okay, so it's 2 minutes to 12 o'clock, and I know that we only had 30 minutes. So we can do it one of two ways. I mean, this presentation is still available to you guys to be used whenever, or we can just spend 5 minutes and see what questions do you have about adverse events, and we can address that. Or we can go through presentation. I will leave it up to you guys. How do you want to do it?
So just a thumbs up, everyone. We could go through the adverse events, and Dr. Thiessen can continue presenting. We do have a little bit more time after, and our agenda isn't quite full, so happy to continue. Thumbs
Okay.
up. Yeah. I don't
Okay,
see any
sounds good.
thumbs up, so. Oh, there's some. Okay, perfect. Oh, and I think there's one. Oh, thumb up, Ricky. Thank you.
Ricky
Yeah,
and Melissa, thumbs up. Okay.
yeah, I think that that works for sure.
Okay, perfect then. So the biggest thing that I'm going to start with talking about is hemolysis that happens with IVIG, and why we ask for a blood group. I mean, IVIG is connected from all donors. We really don't need a blood group to give you the medication. So why do we hunker on and harp on about it? And why is it such a big pain in the butt? Dr. Galley is requesting to annotate the shared content. Should I approve?
No, sorry, that was just a
No.
mistake. Don't do that. Sorry.
Okay, decline then? Okay,
Yes.
fine. Okay, all right. So let's say that you get an IVIG lot and it comes from a pool of donors, and all of them had inherently higher levels of anti-A and anti-B antibodies in their plasma. Anti-A and anti-B antibodies are against blood group antigens which are naturally occurring, and they will both be present in individuals who are blood group O. Okay, and then you have this lot of IVIG, which is completely unpredictable which lot is going to be like that. And you decide to, and you give it to and you make a dose from there and you give it to a patient who is a blood group A or a blood group B or a blood group AB. If the dose is high and the patient size is small, then what happens is that these passive antibodies, which are hanging out in the IVIG product, because it's collected from O donors, can actually lyse the red cells of the patient. Now, this reaction can be extremely mild, where it's not even noticeable, and it can be quite significant. And the significance of the reaction really depends upon size of the patient and the amount of the dose, which is why in pediatric patients, it is a consideration. And I myself have actually entered quite a few adverse, like the Canada Vigilance report for hemolytic reactions happening due to ABO incompatibility with IVIG in females. Usually happens 7 to 10 days post-infusion. You're going to have a pediatric patient with anemia, fatigue, and dark urine. You're going to have, and then, you kind of take things from there. If you are seeing that a pediatric patient who received IVIG gets anemia in the subsequent days, I would say check for hemolytic markers for sure if you haven't checked it already. Send repeat testing to the blood bank for DAT and do an adverse event form, and obviously call us if you need to, and then we can help you work through the rest of the things. It's a one-time event. It usually responds like it's supportive care. If you need to give blood, you give blood and you move on with life. But the thing to know is that if this patient, but that in a patient like this, it is reasonable to consider going to immunoglobulin products that have a lower content of these passive antibodies. Almost every single IVIG brand does something to reduce the anti-A and anti-B concentrations in the plasma in the IVIG product, and none of them are 100% successful. But it's just something for you guys to know and the next steps. The other big one with IVIG is obviously your allergic or anaphylactic reactions, right? So your allergic reactions can happen to literally anything. And why do they happen? Well, if they happen because donor product is carrying antigens against which the patient has made antibodies. For example, the patient has a bad peanut allergy, like anaphylactic level peanut allergy, and somehow the particular IVIG lot that came to you had a significant number of donors who had peanut butter that morning. Like, it's so unpredictable and so random, right? This kid can have a significant allergic reaction. Or it can happen because of another reason, if there are anti-IgA antibodies in recipient, and we'll talk about that in a minute. So if you have the big way to differentiate between allergic reaction and anaphylaxis is your allergic reaction can have your urticaria, like your hives, you can have facial flushing, you can have nausea, vomiting, and you can have swelling of the face, but you should not have swelling of the airway. Once you begin to have swelling of the airway, you have hypotension, you have hypoxia, and you have allergic symptoms. That's when you're going in the anaphylaxis category. And that one obviously needs you to have, and that one obviously requires you to have the anaphylaxis management. And we will talk about that in a minute. So IgA deficiency is interesting, and this is more a physician-heavy concept, but I want to talk about that. So there are individuals quite commonly in our population who will have no IgA in their plasma. IgA is an immunoglobulin which is secreted in our saliva and other secretions, and also has a protective effect against bacteria. But not everyone who is IgA deficient will have an immunodeficiency. Okay, so the patient have no detectable IgA. Sometimes what they do is they form antibodies against the IgA protein itself. So an antibody formed against the antibody, which I always find very messed up, but that is what's happening. Now that antibody is sitting in that patient's blood, and then if you challenge them with IVIG, which is containing some IgA, and IVIG will always have a little amount of immunoglobulin A. You cannot remove all of it, but once again, it's something which the purification process does try to remove to the best of their abilities. They can have a really bad anaphylactic reactions. Okay, majority of anti-IgA antibodies don't cause anaphylaxis. When will you consider IgA deficiency being a problem? Well, you look at a patient who had an anaphylaxis to IVIG, you check their IgA levels. If they're undetectable, that is when you actually test them for anti-IgA antibodies. And if they do have it, plus they had anaphylaxis, that will be the patient that I will put on immunoglobulin products which were taken from individuals with IgA deficiency or solvent detergent IVIG, which we do not use very commonly. So we change the brand altogether to a brand which we know has very low levels of IgA and which is and then we pre-medicate as well, of course, with steroids and antihistamines. So this is going to be your only situation where you will be using, where you will be giving it any preference or benefit. The one thing I didn't talk about in a lot of detail was rate-related events. So rate-related events in IVIG are extremely common. These are your fever, your high blood pressure. You can have tachycardia. You can have pain, especially headaches, and you can have like nausea, vomiting, diarrhea kind of things, and chills and rigors, which can be quite significant. Okay. Rate-related adverse events in IVIG. One second. So first thing for any IVIG reaction that you're going to hear us say is to reduce the rate, because it helps everything. It helps with your common rate-related reactions like fever, chills, headache, and hypertension. It can help you if you're having allergic reactions over and over again, but they tend to be mild. It even helps in severe allergic reactions. When you're anaphylaxis, severe allergic reactions, if you have clear evidence that it was an IgA deficiency related issue, you do three things. You reduce the infusion rate, you pre-treat, and you change the product to a low IgA content. If you do not have an anaphylactic reaction, and even if you have low IgA levels or undetectable IgA, then I would not do this. I will just do like, and you're having mild, then that is not the indication for changing the brand. And then in individuals who are at risk of fluid overload, also rate reduction is markedly helpful. So I would say that, and the individuals who are at risk of fluid overload tend to be individuals over the age of 70 years, not applicable to you. Infants are a big one. And then individuals who have cardiac disease or renal disease and are fluid overloaded at baseline. Also individuals who have compensated anemia. So these are a group of individuals that if you give them too fast or even at the max rate, they can go into fluid overload and get hypoxic and have respiratory distress and all of those things. So it's important to know about that. We do not like to change brands of IVIG if patient is tolerating one brand well. We consider it if a patient is having rate-related reactions, for instance, persistent headaches and fevers and things, and you have reduced the rate, you have pre-treated them with Tylenol, it's still persisting, it's not changing, you can change the brand to another brand, anything. And if you have severe anaphylactic reactions despite pre-medications, then you can change the brand. And for all of these problems, if you are giving a patient IVIG for immunodeficiency purposes, or you're giving them for CIDP, you can consider moving to subcutaneous immunoglobulin weekly. It's given at home. It has a much lower risk of complications. Okay. Indications for pre-medications, we'll talk about anti-allergics. If you have a severe allergic reaction, even one instance, you will pre-medicate with Benadryl or other antihistamines. If you have mild allergic reactions, which are happening over and over again, you would consider that, and then other considerations we talked about. And then diuretics is something, so you have to identify who is at risk of circulatory overload, and then you will consider slow infusion in those patients and pre-infusion diuretics. When we think of infants, I wouldn't give them diuretics just randomly. I would probably say, okay, this is a person at risk. I will infuse very slowly and see what happens. And if they still get symptomatic, then I will use diuretics in the subsequent infusions. Okay, I can go a little bit more, but I think you guys need to do your own things too. So do you want me to stop and leave the rest? It's like 2 or 3 slides left, but it's a lot of talking, heavy slides. Or do you want me to go on? What do you want me to do?
Maybe we could take some questions. We do
let's do that.
have, yeah.
I like it. Let's do that.
So if anybody has a question for Dr. Thiessen
Question in the comments.
Yeah.
It's
Yeah, that's fine
regarding
too.
oral administration. It's regarding the oral administration of IVIG. Oral IVIG is only administered for very select conditions, usually regarding a GI tract, and it will be approved by TMP, obviously. And currently, there is no monitoring or vital signs. We don't have anything pre-made for that, as it's such a rare incidence. Dr. Thiessen, if you want to comment on how often they should be monitoring a patient for oral IVIG.
Melissa, you want to take it? So I will be very honest that we came across the oral IVIG situation for the first time ourselves with a recent patient in the pediatric ward in JPCH. So, it's not something we have dealt with commonly. It's not something we use very commonly. And as you said, it's for gut-related viral infections only. So I do not have a great answer for that, but I can look it up for you. Melissa, do you have something?
We talked about it yesterday in our meeting, and I think that we decided it would be kind of like you're giving somebody an antibiotic for the first time. You're going to want to do your vitals beforehand, and then maybe 15 minutes after, just to ensure there's not a reaction. But there shouldn't be any strong protocol on vital sign monitoring regarding oral administration. Is what I think we decided.
Yeah, that's what I remember as well.
Thank you. Any other questions from anyone? Lucia.
Thank you. Thanks for the presentation so far. Question about the baseline weight. So if it's a certain percentage, we notify you and we change, or the dose gets adjusted. At what point, and this may be dependent on how long the patient is receiving the IVIG, but do the baseline weight, like when do we adjust it so that the baseline weight is higher because of natural growth, or, you know, like, or is the baseline weight always the same as when they first present and indicate the need for IVIG?
So I think that's a good question. Do you want to take it, Melissa? You take it, then I'll take it. If you have.
Sure. Patient should be weighed every time they come in for an IVIG infusion. It's part of the protocol to weigh a patient prior to infusion. So if they're getting like 3 days of an infusion, you only have to weigh them on day 1. So you will be noting the weight monthly. And if you notice the weight has changed, like let's say the patient came in and their order set stated they weighed 22.7 kg, like our order set did, and you notice that it's been 4 months and the patient now weighs 26 kilograms, that might negate a dose change to 12.5. So you can always reach out to us, and never hurts to reach out to the IG Stewardship Program. We are always here to take questions. You can shoot us an email or call us. You'll either get myself or Stephanie. And we have no problem letting you know if we think that a dose adjustment would be required, and we reach out to the physicians to help with that if need be. When in doubt, reach out to us. We'll help you.
Okay, thanks.
Any other questions from anyone?
I did just want to pop out here really quick. I forgot to talk about it. We do have a pediatric pamphlet that we give out to pediatric patients prior to infusion. I did include it as a resource. And I do want to comment that if you have any suspected transfusion reaction, please, please, please fill out a transfusion adverse event report form, a TAER. Even if it's mild or it's just a suspected, it's better to have it documented and investigated than to say, hey, maybe they had a reaction. Also, when you have a patient that comes in, if they suspect that they go home and have a reaction afterwards, please advise them to seek medical treatment. And so let's say they have their IV infusion, they go home, they have a really bad headache. Tell them to go to Emerge to get it properly documented so we can get a TAER filled out on a patient so that they don't come back 4 weeks later and say, hey, I had a really bad headache. I think I had a reaction. Because then we're playing catch up trying to investigate something that possibly happened and is not documented. So that's a really important thing I just wanted to touch base on.
And I will just on the note of headaches. Headaches with IVIG are 2 characteristics. One is your infusion acute headache. So that will happen during the infusion or immediately afterward. And the other one is the one which can happen like anytime between 72 hours to a week later and can be quite severe. For the one which is happening peri-infusion, usually the best thing to do is the rate reduction in pre-treatment with Tylenol, and that is all that, and it works quite well. For the ones that happen a couple of days down the line, they could be of the feature of inflammation of the meninges. So something called as aseptic meningitis due to IVIG, it irritates the meninges of the brain for some reason. So for those, you need a little bit more love and care. You may need to consider switching the brand. You may need to do some other things. So that's just something for you guys to be aware of. That headaches come in 2 flavors. One is your run-of-the-mill rate-related headache, and the second one can be what we call aseptic meningitis. And if it's an aseptic meningitis kind of a headache, then you may have to either change the treatment, switch the brand, do some other things, because those can be quite severe and quite difficult to manage.
Any other questions? Last call. Oh, Dr. Oni.
Yes, I just have a question. You might have already addressed this. So is the PPO ready and approved for use province-wide?
Pediatric IVIG order set went live on June 1st, 2023. And it is available on sasflood.ca. The measles PPO, we're still working on that. One's not live yet.
Thank you.
And I'll send out the links to those as well with our meeting notes. And Ricky, I think you have your hand up as well.
Hi, I just wanted to clarify, like if we have a physician ordering here at the hospital, do they have to submit their request with you guys to get everything cross-referenced and make sure everything's proper and in place?
All inpatient orders actually go to lab for screening and approval. If the patient is an outpatient, all outpatient orders come to us. So you will send an order to lab and they will screen it and send it back to you with their approval stamp on it and if the dose had to be adjusted. And that is actually the order that is supposed to go in the chart. Because that'll have your most recent, if there's been a indication change, like say it was done over 2 days instead of 1 day, or if they wanted to change the dose because it was not calculated properly. So lab does inpatient. The Copy with the IG box that's approved stays on the chart. That's the final copy.
Okay.
Good question, though.
Angie.
Hey, sorry, I just want to follow up with that because I think part of our focus is neonate, so they wouldn't have been given it prior to. So we're wondering if if that's what's given, usually those neonates are going to be sent to the city. Are we looking at a combination joint decision where they request the order for IVIG to be given, indications and everything else there? It goes through for the back check part of it, and then we can give it there, or
So
that's
the
kind of our
IG stewardship
hiccup.
actually, IG stewardship, we don't actually screen neonate orders. Neonate orders, NICU has their own IVIG order set, both Regina and Saskatoon do, and those are the current order sets that are still in play. So it'll be whatever your local NICU IVIG order set is.
And Angie, you may not have one, so we can find
Oh,
those.
I don't know where you are.
Yeah, we can find those and pop them into our rural pediatric network SharePoint as well for people to use and adapt.
I think that's our biggest direction because we're not a NICU, but we do.
You might have to give it. Yeah.
Yeah.
Like
before
on
going
kids less
out.
than
So
2
we're
kg.
trying to find the balance. Thank you, Leah.
So if the child weighs over the 2 kg, then you would do it on the pediatric order set, but less than 2 kilograms would be on the NICU order set, which we can help you locate.
Okay, perfect.
Awesome. All right, well, thank you so very much for coming and presenting on this topic. And I will send out the recording to our contact list and likely include that as a link on our rural pediatric network so it can be easily accessible to everyone. And I just want to really thank Dr. Thiessen and Melissa for coming and spending some time with us and explaining IVIG in pediatrics. It's really appreciated.
No worries. Please feel free to share our emails as well, at least mine. I don't know, Melissa, if you're okay with that, but so that if you guys have any questions that come later, just reach out.
And we do have the IG stewardship email. It's just igstewardshipprogram@saskhealthauthority.ca. You can always reach out to us anytime. And we're going to have this posted on SaskBlood too. So if you ever get bored and you want to peruse, we've got lots of great resources on saskblood.ca. Have a great day, guys. Thank you so much for having us.